hear about an topic on research. It is critical appraisal of literature. And we have Dr. Jean Mathews, who is a palliative care physician from India. And he moved to Canada in 2018 and completed 1 year clinical fellowship in palliative medicine at University Health Network, Toronto, and a 2 year clinical research fellowship in palliative medicine at Princess Margaret Cancer Center, Toronto. And Jean's areas of interest are global oncology, palliative care, advanced pain management, and telehealth palliative care. He has published several articles in peer-reviewed oncology and palliative care journals, and is working on research projects in Canada and India, and to improve access to early palliative care. Currently, he is the assistant professor at Queen's University, Kingston, and he is looking forward to develop local and global partnership to improve palliative care integration. And I also understand that Jean has been searching for biryani and butter chicken in Kingston. And I hope she was able to find it out. So welcome, Jean. And we have another speaker, Dr. Bishal Gyawali, who is a medical oncologist from Nepal. And he has trained and worked in various countries like Nepal, Japan, US, and Canada. He has an MD as well as PhD degrees. He is currently the associate professor in the Department of Oncology and Department of Public Health Sciences, and a scientist in the Division of Cancer Care and Epidemiology, all through Queen's University, Kingston, Canada, and an affiliated faculty at the Program on Regulation, Therapeutics, and Law in Department of Medicine at Brigham and Women's Hospital, Boston, USA. Dr. Gyawali is a member of WHO Essential Medicines List Cancer Medicine Working Group and the ESMO Magnitude of Clinical Benefits Scale Extended Working Group. He is also serving as ASCO's Health Equity and Outcome Committee member. He is also serving as a research consultant to Nepal Health Research Council and has previously served as medical consultant for the not-for-profit Anti-Cancer Fund Belgium. He is in the editorial and advisory board for multiple medicine and oncology journals, including Cell, JCO Global Oncology, JCO Oncology Practice, E&E Cancer. He has co-authored or co-authored more than 100 peer-reviewed articles and is the recipient of 2020 ASCO Conquer Cancer Foundation Global Oncology Young Investigator Award in the Implementation Science. In 2020, Dr. Gyawali was also awarded the Young Health Researcher Award by the Government of Nepal. Dr. Gyawali's areas of academic interest include cancer policy, global oncology, evidence-based oncology, financial possibilities of cancer treatment, clinical trial methods, and supportive care. He is an advocate of the cancer ground shot, a term he coined to imply that investment should be made on proven high-value interventions in cancer care that are easy to implement globally and are affordable. So, welcome, Dr. Bishal Gyawali, and it's over to you, Jean and Bishal.
Thanks, Sunil. I think someone from the Pallium team, could you upload the slides? Okay, great. So it's nice to see you all again. So today we're going to do a critical appraisal demonstration of this study, which is called effect of chocolate in older patients with cancer. This was a randomized controlled trial, which was published in the last year. Sunil has already introduced Bishal, but I will just say personally, like I am a beginner in this topic of critical appraisal in palliative care, but Bishal is a globally renowned expert in this topic, and his critical appraisals of oncology drugs regularly appears in the Lancet and Nature and New England Journal of Medicine, and is even kind of impacting what the US FDA does. So it's a huge privilege to have Bishal here, and it is Bishal's presence that kind of truly makes this a masterclass in critical appraisal. So maybe we can go to the next slide. And we don't have any disclosures relevant to this study. Next slide. So this is what we're going to talk about today. We're going to talk a bit about why we need critical appraisal, what is critical appraisal, what are the steps of it, and we will use this Vittori 2022 study just to demonstrate critical appraisal. And I said already, we'll hear from an expert. So Bishal will kind of jump in with comments at any point in my slide deck, and after my slide deck, he's going to present another slide deck with another paper, just as an example of some further points in critical appraisal. Hopefully, all of you had a chance to review the Vittori 2022 paper, just so that that'll make it a bit more interactive when we actually do the critical appraisal. And I know Bishal shared one paper yesterday as well, so you can take a look at that as well. Next slide, please. So why do we need critical appraisal? So if you actually read the news on new drug trials, every day you'll see something about a new groundbreaking cancer treatment or about some new earth-shattering Alzheimer's treatment. So there's a lot of hype whenever you read these news stories about potential new treatments. But you can't always trust everything you read. So it's important to have the skills to read a research paper and systematically examine, are these results valid? Are they reliable? Are they relevant to my practice and my patient population? So those are, some of the reasons why it's important to do a critical appraisal. Next slide. You're all familiar with this pyramid, which is the evidence-based practice pyramid. So at the bottom of the pyramid is kind of the least quality of evidence, which is expert opinion or anecdote or whatever is common practice. And then as you go up the pyramid, the quality of the evidence increases. So you see randomized controlled trials over there, and then all the way at the top, it is a systematic review. So this kind of shows you the quality of evidence that we look at when we're appraising a study. Next slide. So evidence-based medicine or evidence-based practice, it can be thought of as comprising of these three things. So the first one, which is our topic for today, is how to appraise evidence. The other two things that are important, one is your own clinical experience. So it's not only about what is the latest study drug that is out there for a particular indication, but what is your clinical experience and is it relevant to your clinical experience? And the third thing that's important to consider, and probably the most important, is what is the patient's preference? So even if you know of some new study drug and you have some experience with it, what matters the most is it something the patient is interested in? Is it treating a condition that the patient feels is impacting their quality of life? So all of these things together make up the evidence-based practice. Next slide.
Jim, sorry, can I interrupt
go
you
ahead.
for a second?
Yes.
About the evidence-based medicine pyramid, I wanted to
yes.
Sorry, can I interrupt your slide and show a couple of mine?
Yeah, absolutely.
I just wanted to let people know that, yes, this is the classical. Can you see my slide? Just I want to show two slides.
Yes.
So this is the classical evidence-based medicine pyramid that we talk about, where there is hierarchy and the quality of studies. But at the end of this critical appraisal course, I want people to know that simply because one study is RCT does not make it a high quality study, and simply because a study is an observational study or a cohort study does not make it a low quality study. It depends on what the type of research question is and whether that study type is best suited to answer that research question. So this is a joke, but I think a better evidence-based medicine pyramid would look something like this. This is I copied this from one of my colleagues on Twitter, but what matters is not whether it's an RCT versus a not RCT. What matters is whether it's a really well conducted, thoughtful design study of any type that is pertinent to answering that question versus all the other, like we have so many garbage RCTs, so to speak, which are worse than not having an RCT. Sorry, please go ahead. I just wanted to make that point.
Thanks, Bishal. I love that pyramid that you shared. I'm gonna have to steal that pyramid now. Okay, so next slide. So now, we talked a bit about why we need to do a critical appraisal. Now we'll get into, what exactly is a critical appraisal. So it's defined as a systematic examination of research to assess its validity, its trustworthiness or reliability, and its relevance to your own practice, to your own clinical decision-making. So validity refers to the extent to which a test measures what it is supposed to measure, or the extent to which the results are true for the sample that is studied. So are there any biases, any systematic biases that can overestimate the results and make the study invalid? So that's the first aspect of it, is the validity. The next aspect is the trustworthiness or reliability of the findings. So that refers to how consistent a test is on repeated measurements, or how consistent these tests or these studies will be if they are repeated. And then the final point is, what is the value and relevance of this study to your own individual practice or for your own patients? Next slide. So this is, again, just another way of looking at the appraisal framework. I was just sharing this just so that you know that there are actually tools that you can use to appraise different types of studies. So the AmStar is as a tool to appraise systematic reviews. CASP has a number of tools. So they have tools for qualitative studies, tools for quantitative studies. Consort is for reporting guidelines on RCTs and things like that. We won't go into each of these tools separately, but I just wanted you to know that these tools are available depending on the type of study that you want to appraise. You can use these tools, but what I will present is just a general kind of approach to do a critical appraisal. Next slide. So we talked a bit about bias. So the bias is defined as an error at any stage of a study that is not due to chance. So bias leads to results which are a systematic deviation from the truth. And as you can see on the slide, bias can happen at any time in the trial. So during the planning stage, you can have a flawed study design. You can have selection bias, which is basically when there's a difference between the sample of your study and the target population. You can have bias while you're implementing the study. So during our demonstration, I'll talk a bit about recall bias. And then you can have bias after the trial. So citation bias is when authors will cite papers that confirm or support their own findings. Publication bias is another common bias where it's easier to publish positive results rather than negative results. So this is one way to look at bias. Next slide. So this is another way to look at issues in study design, implementation, and bias. This is actually from Bishal's paper, which was published in ESMO Open in 2021. So I'll invite Bishal to actually speak on this.
And thanks, Zin. Yes. So this was in reference to the ESMO MCBS tool. MCBS is a tool that ESMO has developed to help evaluate the value of cancer drugs, but I think this is applicable for any randomized clinical trial or any clinical trial. So this provides like a 10-point checklist that you can use when you are evaluating a clinical trial. For example, the first point here is there even a control arm? That means, is it an RCT or not an RCT? If there is no control arm, if it is a single arm trial, then probably the results that you get will be falsely better than what you would see in a randomized trial. This has been proven with cancer drugs. And the other thing that you look at control agent, if it is a randomized trial and there is a control arm, is that the control arm that you would have used for your patients outside of the clinical trial? That means, is it the standard of care? Sometimes you see a control arm that is beneath the standard of care. That is, and then you will find positive results in the trial, not because the interventional arm is better, but because the control arm is worse. Then there are a couple of issues related to non-inferiority design trials. Non-inferiority design trials are a little different than our classical superiority trials. And one important thing to look at non-inferiority design trial is, one, whether the non-inferiority design was justified, and second, how did they define non-inferiority? Because that is oftentimes very arbitrary. People can say that up to 50% increase in mortality is non-inferior, and then they can claim non-inferiority, which is not acceptable to us. So how did they define non-inferiority? And the other one is whether the trial is looking at overall a clinically meaningful endpoint or a surrogate endpoint. And if they're using a surrogate endpoint instead of the clinically meaningful endpoint, is the surrogate endpoint validated for the clinical outcome, or is it a false surrogate? And then there are some issues related to informative censoring that might be a little too much into depth to talk today, but informative censoring happens when patients in the intervention, in the experimental arm and the control arm, they are dropping out of the trial for different reasons, which defeats the purpose of randomization. And then there is the issue of crossover. That means whether the patients in the control arm got access to the experimental agent after they progressed. And sometimes it is important to have crossover, and sometimes it is not important to have crossover. There should not be crossover. So there are nuances to it. And then there is the issue of what treatment did they get after progression of the trial? Did they get a standard of care or not? And was the trial stopped early? Usually, as a rule of thumb, if a trial is stopped early, then it shows higher benefit than it actually is. And then what about the quality of life reporting? Did they report on, this is especially for cancer drugs, did they report only on survival outcomes or also quality of life? And finally, there is the issue of subgroup analysis. Nowadays, people claim several interventions are practice changing based on subgroup analysis, and whether those subgroup analyses were pre-planned, post hoc. If it is post hoc, then it's more likely to be false positive. So I think like we explain all of these points with examples in this paper. So I would highly recommend you to go through this paper.
Thanks, Bishal. We can go to the next slide, which is also from Bishal's paper, so you can comment on this table as well.
Yeah, so it's basically like what I just explained. How do we make sure that the study that we're looking at is a valid study? So as I mentioned, what was the hypothesis of the study? What was the primary outcome? Was it a surrogate or a clinical outcome? What was the magnitude of benefit that the study was targeting? There is something called overpowering the trial, which I can discuss later. That means, you know, the difference between statistical significance versus clinical meaningfulness. You can find a p-value of less than 0.05, but whether that difference is clinically meaningful or not. What was the type 1 false positive error rate, false negative error rates? And as I mentioned in the evidence-based medicine pyramid thing, it has to be an appropriate study design, not necessarily one study design, whether that was the study design appropriate to answer the question that we're looking for. And the issue about control arm, as I mentioned. And the fourth one is about actually the validity of the study. And there is both the issue of internal as well as external validity. External validity is the result from the trial applicable to the patients in the clinic, because if the patients participating in the trial are uniquely different, and this happens in cancer trials all the time, because we enroll patients who are very fit, who do not have other comorbidities in cancer drug trials, but in real life, these patients will have cardiomyopathy, diabetes, hypertension, all the comorbidities, kidney failure, and we do not know whether those results will be valid or not. And no statistical plan, whether it was clearly outlined before the trial and whether they stayed with the plan or whether they deviated from from the plan. And the last one, conjectural conclusion, it just means conclusions deriving based on subgroup analysis without any pre-planned. This happens oftentimes in cancer drugs. Like, you find that the overall trial is negative, but then you run 50 subgroup analysis and you find that, okay, maybe the drug is beneficial in this one small subgroup of patients. But if that is not pre-planned and has not been powered for that, that is more likely to be false positive.
Thanks, Bishal. We'll move to the next slide. So these are kind of the steps that we take when we systematically evaluate a study and do a critical appraisal. We can actually start with the demonstration and go through these steps. So we can go to the next slide. Okay, so we're going to now, we've completed the theory aspect. Now we're going to actually do a practical demonstration of critical appraisal. We chose this paper because this was actually, it was published in the last year, and it caught a lot of headlines. So in the recent American Hospice Palliative Care Conference, which was in Toronto in the last few months, this was one of the top 10 papers of 2022. And that's how it caught my attention. And then when I read the title, it was such a attractive, interesting title that I thought, this will be a good randomized control trial for us to discuss with the group. And, hopefully you've had a chance to review it as well. So starting with, just the title and the author list, some of the things we look for. What is the journal that published it and which year? So this was published in BMC Palliative Care. So it's a relatively kind of average impact factor type of palliative care journal. So it has an impact factor around 3. It's not as high as the highest palliative care journal, which is Palliative Medicine, which has an impact factor of 5. It's certainly not as high as the oncology journal. So, if you look at, the Lancet or others, they have impact factors higher than 50. So this just gives you a sense of, where this was published, which can be an indirect measure of, what was the quality of the RCT, although that's not necessarily true. I don't know whether they have tried to publish at a higher impact factor before, or this was, the first place where they submitted this. But that's something we always look at. You always look at what year it was published. So it was in the last year, and it was one of the top 10 papers of the last year. We know that it is a randomized controlled trial, as you can read from the title. The other thing I look at is, who are the authors? Are these authors that I know from my reading of palliative care research? Are they one of the institutions that regularly publishes high quality kind of practice changing studies? For instance, the MD Anderson group in Texas, they are a powerhouse in palliative care research, or the Massachusetts General Hospital, or a few other authors that personally I look to and I follow. So those are some of the things I look at. I'm not familiar with these authors, but I see that this was done in Brazil. So, it tells me that, possibly this is a trial that might have relevance in a low middle income country setting. And that is important, because most trials in palliative care are done in high income countries. So it's important from that aspect. Next slide. The next thing I go to is actually I jump from the top to the bottom of the paper. I'll look at, what is the funding and any other conflict of interest that has been declared. So especially for, industry funded drug trials, you want to know, did the authors also get funding from the industry or this particular pharmaceutical? Are they getting, paid speaker fees, or are they getting other consulting fees, which might be a conflict of interest here? In this case, the study was funded by, academic university hospital funding, and they did not declare any other conflict of interest related to the research. There was another statement that they got the chocolate for free from some chocolate company, but there was no conflict associated with that. But that's something we look for as well. Next slide. So the next thing you want to look at is what is the rationale for the study? What is the gap in the literature or unmet clinical need that they're trying to address? Usually you will find this in a good introduction section of the article. They should mention references to earlier work that is related to the area that they're studying, and then talk about what are the limitations in the previous literature. So identify what is the gap that they are trying to fill with this particular study. So if you just look at the references without even going to the introduction section, I've just listed the first 8 references here. So the first one, it's talking about projections for mortality and causes of death in the future. So it's telling you about, cancer-related global burden, it's increasing. The next one is about the role of early palliative care in advanced cancer. The third reference is about the role of nutrition counseling, and association with quality of life for patients with cancer. Then there's another study about cancer-related malnutrition, and then there's something about chocolate and the role of chocolate as a food for mood, the role of cocoa as a biomarker of inflammation, and again the role of nutritional support in quality of life for patients with cancer. So I can already, just by reading all these references, get a sense that, okay, they've identified that there's nutrition is an important quality or a quality of life factor in patients with cancer, and they're studying chocolate as a nutritional supplement for patients with cancer. So it gives me an idea of the rationale for the study. Next slide. So they say that there are a few studies about the impact of nutritional intervention in quality of life, especially with relation to chocolate. And so in view of this, the main objective was to assess the effect of chocolate on nutritional status. So that's their primary outcome for older cancer patients in palliative care. And then they list some of their secondary outcomes as well. So that's about the rationale. Next slide. Now we go to the methods. So we already know this is a randomized, now we know it's a non-blinded clinical trial. It was at the University of Sao Paulo in Brazil. It's important to note that they have research ethics approval. So that's an important thing, to make sure that there is approval and that we note any ethical concerns. And then you see on the bottom here that this was registered in clinicaltrials.gov. So ideally, as Bishal had stated in his table, you want a statistical plan, an analysis plan to be preconceived before you actually start the study. And so one of the things you look at is to make sure that the protocol has been registered. Next slide. So I actually went to the protocol to see what they had registered. So according to the protocol, this was study start date was in April 2016. It was completed in July 2019, but the protocol was only registered in April 2020. So after the study, which usually is not ideal. Maybe there's a explanation. Maybe they registered it in Brazil and then later registered it in clinical trials, or maybe they forgot or something like that. But ideally, a high quality RCT will have a protocol that's registered before the actual study is started. In their protocol, you see what are their primary and secondary endpoints listed. Now we'll go to the next slide where we look at the paper itself. So you can see that there's a difference in the endpoints that they list between the protocol and the paper. In the paper, they have only one primary endpoint, which is the nutritional status assessment using mini nutritional assessment. And then a lot of the other primary endpoints in the protocol, they actually move down to a secondary endpoint when they came to the paper. So again, I don't know what is the background to this, whether there was a innocent explanation for this, but say this was an industry funded trial where, we know in industry funded trials, they have a tendency to hype their results. It's very possible that, they can do what is called data trawling, where they do a whole bunch of analyses, and then the ones that are positive, they report as their primary, and then the others, they either omit or report as secondary. So ideally, you want primary and secondary endpoints to be fixed before the trial, and they should be consistent with that in the protocol and in the paper. Next slide. So the next thing we do is do a PICO or PICO analysis, so population intervention control arm or comparator, and then outcome. So looking at their population, they were looking at age more than 60, patients with a cancer diagnosis and having outpatient follow-up in palliative care. KPS performance status score more than 60%. So that's fine for a palliative care clinic population. A PPS more than 60 is fine. It would be representative of the target population. And then their exclusion is PPS less than 60 and a few other things. One of the things we noted is they're not targeting an at-risk population. So if their primary outcome measure is nutritional status, why didn't they target a population which was malnourished, or a population which reported high appetite scores, or low appetite, or a population that had a high risk of cancer cachexia? They didn't target that population, and I'll come back to that later when we discuss the results. Next slide. So we look at the randomization. They have three groups. They have a control group, a 55% chocolate group, and then a white chocolate group, 15 patients per group. And they justified this based on previous RCTs of chocolate in non-cancer population. So that's another thing we want to look at. What is the sample size justification? So they made a statement that the control group was instructed not to consume any extra chocolate, but they could eat other snacks. So, I wondered about the ethical concerns related to, stopping people from eating chocolate if they wanted to eat chocolate. Also about the recall bias. Is it possible that people in the control group could eat chocolate and then forget to mention that in their food survey questionnaire? And then they make a statement, no participants had habitual chocolate consumption before the study. So how did they define habitual? Was it, one chocolate a day or one chocolate a week? They don't mention that. So there is some recall bias that's possible, some misclassification bias that's possible in this randomization. Next slide. So we know that it's a unblinded study design. Does anyone have any thoughts on what possible bias can be there when a study is unblinded, especially if this study is unblinded?
A performance bias?
Exactly. So you can have a bias where the people who know that they got the chocolate, you can't, that they will know that they got the chocolate, and then when you ask them to answer a survey, that might bias their response and their feeling of how the chocolate helped them. So obviously you want to try and blind as much as possible to reduce the risk of that kind of response bias. Next slide. So as I said, the control group was instructed not to consume chocolate. One thing that Bishal had brought up was the role of control group, the possibility of a substandard control group. So if a substandard control arm is used, it may bias the outcome because it'll generate a larger benefit for the intervention than if a standard of care had been used. In this study, because they're not targeting a population with malnutrition, it's fine to have a control group that is basically, just a passive control group. They're not consuming chocolate. But suppose this study was targeting an at-risk population. Suppose they were targeting patients who were all malnourished. Then there actually is a better standard of care than just to say no to consume chocolate. You could say standard of care is referring to a dietitian to get advice on nutritional supplementation. Standard of care could be a trial of a short course of steroids to improve appetite, or a trial of mirtazapine or olanzapine, or one of the other medications which has been studied to improve cancer cachexia and nutrition in patients with cancer. So that's something to keep in mind. In this study, it didn't make too much of a difference because they're targeting a general cancer population. Next slide. So this was done at a single site, so which might mean that they have one type of patient. So the results may not be generalizable to other sites. Ideally, you want a multi-site study where there's a broad range of ethnic groups that are included. Next slide. So this is the actual intervention. So 25 grams of either the 55% chocolate or the white chocolate daily for 4 weeks, and the control group got nothing. And they used 5-gram tablets times 5 tablets per day. So, one of the comments was about maybe not being able to blind this, but if they had these tablets, they could have. I don't know what the tablets look like, but it's not actually a chocolate wrapped in a wrapper. So they could have created a sham tablet which does not contain chocolate, but they didn't create any such tablet. So it was pretty easy to know that you were getting an intervention. And then they recorded daily on a card the amount of chocolate consumed. Next slide. So coming to the outcomes, so their primary outcome per the paper was nutritional status using the MNA. So one of the things you want to look at when you look at the outcome measures is it validated for the patient population? So this is a measure that's validated in Brazilian population, and it's validated in a geriatric cancer population. And the other thing you want to know is what is a statistically or what is a clinically significant difference in the score. So if the MNA score improves, how do you know it's just statistically significant versus how do you know it's actually a meaningful clinical improvement? So we know that a difference of 1.8 points was considered clinically significant. The other thing I looked at, so it's a score totally, the maximum score is 30. I wanted to know what is the cutoff for malnutrition. So a score of less than 17 is considered as malnutrition in the MNA assessment, and we'll discuss the relevance of that when we talk about the results. Next slide. So the first thing we look at when we look at the results is the demographic. Is it a demographic that's representative of the target population? Is it representative of your population of patients? So mean age was 67. You see the mean KPS was 88. So when I read this, I was quite shocked. So in my palliative care clinic here at Queens, that's a very fit patient if they have a PPS of 90. Usually our average population in the cancer palliative care clinic has a PPS of maybe 60. So, this is something that's important to know, that they have a very fit a mean KPS, which may mean that there is a selection bias. It may not be generalizable. The other thing to note is they reported that the mean chocolate consumption was quite good. So they had a good adherence to the intervention, reported good appreciation of the taste of chocolate. So obviously that's self-explanatory. And then the other important thing is the demographic factors showed no significant difference between groups. So you want to make sure that you always see a statement like that, that there's no difference between the groups, because if there is a difference between the control group and the intervention group, say if the control group is a sicker population, then again, that magnifies the effect of the intervention. Next slide. So usually the figure 1 in RCT is the flow chart. So it's always good to look at how many patients were assessed and how many were randomized. So we see that 46 were randomized, about 15 per group. And then you want to know how many dropped out. So, did the intervention have some kind of side effect or low tolerability that led to a lot of people dropping out? In this case, the intervention is chocolate. So as expected, only 1% dropped out, and that was because they died, which is a known kind of issue in palliative care trials. And then the other thing you want to look at is how did they analyze the data? Did they do an intention to treat analysis, or did they do a per protocol analysis? In this case, they analyzed all of the outcomes. So next slide. What is an intention to treat analysis? So basically what that means is all of the patients that were randomized to the treatment are analyzed according to their group assignment, regardless of what treatment they received or if they even received the treatment. So, if a patient is randomized to a drug for 2 months and then they drop out after 2 days because of side effects, if you're doing an intention to treat analysis, they'll still be included in that analysis. The other type of analysis that can be done, it's called a per protocol analysis, which basically means that you only include the patients who received the study drug according to the protocol. So the per protocol analysis will usually tend to overestimate treatment effect because it excludes those who dropped out. So usually they say that an intention to treat analysis is considered to be a better way to analyze the data, but I understand that there are exceptions to this for non-inferiority trials where both the intention to treat and the per protocol analysis are important. Next slide. So table 1 in an RCT is usually the demographic data. So, as we saw before, there was no significant difference between the groups. So the control group, IG1 is the 55% chocolate group and IG2 is the white chocolate group. So you see here 59% were male. For some reason, they didn't report the age by group, which is something usually they do, but they didn't report that here. In terms of ethnicity, 85% were Caucasian. So obviously, if I was reading the study in India, that it's good to know that they used a mostly white population. In terms of education, 61% were up to 8 years of education. So this basically gives you a sense of what is the generalizability. Does it apply to your clinical practice and patient population? Next slide. So this is the main kind of their primary outcome data. So you see the M&A score is highlighted there, and to read this table, so you have the control group as the first column, and then IG1 is the 55% cocoa, and then IG2 is the white chocolate. And then you have baseline here, and you have end of study over there. And so the highlighted number shows that there is a clinically and statistically significant improvement in nutritional status in the 55% cocoa group. So if you look at M&A total assessment, it went from 22 all the way to 24. And as I stated previously, 1.8 is a clinically meaningful change. So there is more than a clinically, the minimum clinically meaningful change. But one of the things I had looked at earlier was what is malnourished in this score. So 17 is defined as, less than 17 is defined as malnourished. So if we go to the next slide, we'll look at what is in our baseline, what is the percentage of malnourished in this sample. So you see here 0 in the control, 25% here. This is for screening, and there's just one person there. And if you look at the total assessment, 0, 13%, 6%. So basically, the rate of malnourishment in this sample is very low. So the condition that they're trying to treat, their primary outcome is nutritional status. The malnourishment doesn't even exist in this patient population. If you look at the BMI, which I've highlighted here, their BMI is actually showing that they're all overweight. So the mean BMI in all three groups is actually an overweight BMI. So it brings to mind the question, what are they actually trying to treat here? Their population is so fit that they're actually all overweight. So why are they looking at nutritional status in this population? Next slide. So some of their secondary outcomes, so you see BMI and body composition, they didn't change during the study period. Quality of life, it was clinically significantly improved in the 55% COCO group, but in two domains, the social functioning and role functioning. So role functioning basically means like, are they independent for their daily activities? Are they able to perform their daily roles like, dressing, bathing, all that kind of thing? And social functioning is, are they able to function in society? Are they able to maintain their social role in the family and their friend circle, things like that? So both of this increased in the intervention group, the 55% COCO group, but we'll take a closer look at that in the next slide. And they looked at albumin. So albumin, which is a marker for nutrition, showed no change during the study period in any of the groups. The other thing they looked at was IG, the intervention group 1 had an increase in polyphenol intake, and polyphenol is an antioxidant. So I don't know whether that's actually something I really care about in my patient population, but they reported this as a statistically significant increase. Next slide. So this is the quality of life data. So the second main finding was that there was a clinically significant improvement in quality of life, role, and social functioning. So the minimum clinically significant difference here is 10 points. So if there's a 10-point difference, it means that there's a clinical significance. And you see here, it goes up in the IG1 group from 60 to 83. So this is a clinically meaningful difference, and it goes up the same in social functioning. But what do these numbers mean? The 60 and the 80, how does that compare to a general population? That's important to know when you want to assess or appraise this data. So in the next slide, I tried to find what is these scores in a general population. So average non-cancer patient population. Next slide. So you can see this is the same QOL measure, but this was taken in a general population. So you can see role functioning, the mean is 84, social functioning is 87. And if you remember from the previous slide, in the baseline of the cancer patients, that was actually significantly less. It was, it was 60 and 72. So this is actually meaningful that there is a significant difference between the cancer population and the general population. And there was a clinically important improvement because of the intervention. But the other thing I noted here is if you look at their global health status, the mean global health status in a general population was 71. And the mean global health status in our study population was in the 80s. So again, this was a population that is generally good global health status, better than a general population. So they ended up choosing a sample which was very well nourished, very good global health status. Their fatigue score is actually better than a general population. So again, is this selection bias? Is this generalizable? Those are some of the questions you have to ask. And if you don't try to appraise it this way, if you just look at the data and say, oh, there was a clinically significant importance, a clinically significant improvement, you may not get the whole picture. Next slide. So the other thing you always look at in a trial is the safety data. Obviously, it's not as relevant when your intervention is chocolate, but this is something you look at. In this case, they had good adherence to the intervention and no safety concerns. Next slide. So you also want to read what are the limitations that the authors describe. So they talk about a small number of subjects, short period of intervention, and they suggest that future studies should explore the mechanism between chocolate consumption and effect on health and quality of life. So next slide. So now I'm just going to summarize my critical appraisal. So we know that between the trial registration and the study publication, it looked like there was a change in the endpoints between the protocol and the final paper. The trial was registered after the study was completed, which again is, we don't know if there was an innocent reason for this or whether there wasn't. One of the questions I was asking is, why is this only being done in older adults? So, any age group with cancer is at risk of cancer cachexia. So why did you need to restrict it to age more than 60? As we talked about, the mean performance status was a super fit 90%, which makes it less generalizable, at least to my clinical context. We talked about the bias of it being unblinded. We saw that the baseline population is actually very well and in fact overnourished. So what was the benefit in this study sample of improving the nutritional status in the intervention group? Why didn't they target a population that was actually more malnourished, so to see if this improved nutritional status? We know that the baseline QOL scores were quite comparable to the general population, again showing that this is a very healthy cancer patient population that they chose for this trial. Two of the kind of objective measures of nutrition, BMI and albumin, didn't actually change in any of the groups during the study period. And one of the other things that I was wondering about was, why didn't they measure mood? So, in their introduction, they talked about the role of chocolate to improve mood. And certainly that seems like a very plausible idea that, when we eat chocolate, we all feel better because of it. So why didn't they actually measure mood? And did they actually measure mood and they didn't find a benefit, and that's why they didn't report it? I don't know, but I thought that that's something they should have measured. And final slide. So at the end of a critical appraisal, the last question that you always ask yourself, does this change my practice? So, related to this paper specifically, I don't think this changes my practice in any way. If my patients want to have chocolate, I'll encourage them to have it. And, if they didn't want to have chocolate, I wouldn't say that you need to have chocolate because this study says that it improves your nutritional status. I'm not convinced that at the end of the study that I think that. So that's kind of a demonstration of a critical appraisal. Maybe now I'll just invite Bishal, whether he has any further comments on this, or whether he wants to share another paper and demonstrate some other points on critical appraisal.
No, thank you, Jim. This has been a very good learning exercise, I hope, for everyone. I have almost nothing to add to what you have just explained, but I can explain a couple more points using a different paper. So let me share my slides. Can you see my slides?
Yes.
Okay. Yeah, so I had sent this paper yesterday in the last minute, but it's okay if you haven't had the time to go through it. We'll go through it together. I just want to highlight a couple more points using a trial of a drug, but also in palliative care or supportive care, so that there are some nuances that are more applicable for drug trial, and I wanted to highlight that. So this is the paper that I want to talk about. This was published in 2016 in the Lancet Oncology. This is a new drug called enamorelin for patients with cancer and cachexia, the Romana 1 and Romana 2 trials. So I was surprised to see that they combined results from 2 randomized trials and published it together. So let's go to the conclusions of this trial, this publication. What was written in the conclusion? The conclusion says that considering the unmet medical need for safe and effective treatments for cachexia, enamorelin might be a treatment option for patients with cancer, anorexia, and cachexia. It might be a treatment option. And then it further says that the increase in patients' weight with enamorelin was early and progressive, with significant differences emerging as early as 3 weeks. Patients assigned to this drug also had a rapid and sustained improvement in their anorexia and cachexia symptoms. In a debilitated population, such a rapid attenuation of cachexia and associated symptoms is clinically important, especially in patients with a short survival. So the reason I'm highlighting this paper is, we usually look at journals like Lancet, New England Journal, JAMA with a very high regard, and oftentimes we do not even have access to the full paper. We read only the abstract, but even if we are reading the full paper, we want to read the conclusions first, because we think that the conclusions of such big impact factor journals have been vetted and are trustworthy. That is our impression. So we want to read the conclusion and make an impression based on that. So I want to show you today that simply because a paper is published in a very high impact factor journal like New England Journal or Lancet or JCO does not necessarily mean that you can give away your critical appraisal skills and can just cross the conclusion. No, in fact, it's all the more important to read these papers with more critical appraisal insights because of the stature, because most of the trials that are published in these big journals are supposed to be practice-changing trials. So if you read this conclusion alone in a journal like Lancet Oncology, you would think that, okay, this is a new drug. This can be a treatment option for my patients with cancer cachexia. I should start using this. So that would be the impression that I would get from reading this conclusion alone. But let's look into the paper. I'm not going into as detailed as Jean did. You already saw how to go through a paper. I'm just going to highlight a couple of points that are important. So you see that conclusion, then what do? You look into the method. So what did they actually do? So these 2 trials, they tested this new drug, enamorelin, in patients with advanced non-small cell lung cancer, but who also had cachexia. So you'll need to look at how they define cachexia first, and then they randomize patients, huge number of patients, 484 and 495 in these Romana 1 and Romana 2 trials. They randomized 2:1 to receive either the drug or placebo. So the control arm is placebo here, which is fair. We don't have good drugs for cachexia. We might use some steroid, but placebo per se is not a bad control. But I'm intrigued by them using 2:1 randomization instead of 1:1, because when you use 2:1, 3:1 randomization, in a sense, you are saying that I already know that the drug is better, so I want to keep more patients on the drug and less patients on the control arm, which defeats the purpose of doing the trial. If we already know the results of the trial, then there is no need to do the trial. But more importantly, it introduces some methodological challenges, and you will end up requiring more patients. And then we look at the primary endpoint of the trial. This trial had 2 primary endpoints, co-primary endpoints. So they wanted to see over 12 weeks, over a 3-month period, what is the median change in lean body mass and hand grip strength. So basically, they want to see the change in muscle mass and muscle strength over a 3-month period, which is fine. I think these are important endpoints for patients with cachexia. And these are the results. So as I mentioned, 484, 495, these are a big number of patients. So these are the results. So lean body mass. Patients on the drug, they gained some muscle weight. Patients on placebo, they lost some muscle weight. But if you look at the difference, it's less than a kilogram in either case, 0.99 kilogram with plus 0.99 kilogram gain in a little less than 1 kilo muscle mass with the drug versus loss of almost half a kilo muscle mass in Romana 1 trial, gain of 0.65 kilo of muscle mass versus loss of almost 1 kilo of muscle mass in Romana 2 trial. And this difference was significant, statistically significant. P-value was less than 0.0001. But what about hand grip strength? That was the primary endpoint. The hand grip strength was unchanged in both. As you can see, the hand grip strength was a loss of hand grip strength by 1.1 kilo with the drug versus 1.5 kilo with the placebo, 1.48 kilo loss with the drug versus 0.95 with the placebo. So absolutely no difference in muscle strength. And what about toxicity? Diabetes and hyperglycemia were the commonest side effect of this new drug in almost 5% of the patients. But this was not too bad a drug in terms of side effect. Less than 1% had treatment discontinuation due to toxicity. No patient needed dose reduction. So what are the issues? We saw the conclusions, we saw the results, and we briefly went through the method. So once we look into these conclusions and these methods and results, what comes to our mind? What are the issues with this trial? I guess it's not very interactive because we are not doing this in person, and getting your feedback might be difficult, but yeah, let me go through it. So these are the issues that I thought were important in this trial. First, let's look at survival. The survival was 8.9 months with the drug versus 9.2 months. I don't want to look at survival because this is a cancer drug. This is not a cancer drug. This is for cachexia. So survival should not matter. But why survival matters is I want to look at the prognosis of the patients. So it's almost like 9 months, around 9 months survival for most of these patients. And why is that important? So we need to keep everything into context because we are not treating muscle mass. We are treating people with this muscle mass. So let's think about it. For someone who has 9 months to live, if it's a drug that's not going to change their muscle strength, but just increase their muscle mass by less than a kilogram, do you think it's going to make a difference for someone who is going to die in 9 months on average, having less than 1 kilo of extra lean body mass? But there are more issues. The other is the article does not tell us about confounders such as nutrition, social support, financial status, exercise status. We know that all of these factors have an effect on lean body mass. People who are more into family, who are more rich and can afford better food, or are conscious and make a point to help their patients with to the family members with cancer to mobilize more, to eat more, they will have more better lean body mass, but we do not know about those confounders in this trial. And then even then, the increase of lean body mass was 1.5 kilo. I'm saying 1.5 kilo because we need to compare versus placebo. In placebo, they are almost losing half a kilo of muscle, and in the drug arm, they are gaining almost 1 kilo of muscle. So the difference is 1.5 kilo. So it's a difference of 1.5 kilo with the drug versus placebo in the last few months of life. Is that meaningful? This is all the more important to ask because there is no improvement in muscle function, because the hand grip strength, which is a proxy for muscle function, was absolutely negative. So what's the point? You have 1 extra kilo of lean body mass, but your muscle function, your muscle strength does not change. So basically, we are talking about a patient in the last few months of their life. Would they care whether they have a few extra grams of muscle if they cannot open the door or take a walk? What matters to our patient is muscle function. Whether, previously they could not button their short, now they can button their short by themselves. Previously they could not go to the bathroom alone, now they can go to the bathroom by themselves. So that would be more meaningful. Even if the results showed that the muscle mass did not improve a lot, the muscle mass improved only by 100 grams or did not improve, but the muscle function improved substantially, I would be happy to use the drug. But it's the other way around. There is some increase in muscle mass, but absolutely no change in muscle function. So yes, muscle mass is statistically significant, but as I was briefly mentioning before, I think that is due to overpowering of trial. Overpowering means enrolling more patients than is needed. So if you enroll a lot of patients, any difference will be seen as significant. So this increment in lean body mass, it's all the more problematic because we are not even sure that this increase in lean body mass is due to increase in skeletal muscle mass alone, because in this trial, they did not measure tumor response. So there is a chance that some part of this increase in body mass could be due to things like ascites, effusion, or just increase in tumor burden, because tumor response was not measured. So this is small delta in lean body mass could be due to delta in tumor burden. That is a possibility. And they in fact measure a couple of other factors related to quality of life, but they specifically measure fatigue, and even fatigue did not improve. So even fatigue had no change. So basically, we are just adding a few grams of muscle without, and that is not translating into something meaningful. So if it does not translate into something meaningful for the patient, then these are just numbers. Why does it matter to say, okay, I have 50 kilogram weight versus I have 51 kilogram weight, if it does not translate into anything meaningful? And in fact, in theory, there are some concerns that this drug might even promote tumor growth by increasing concentrations of growth hormone and IGF-1. And as I showed, the survival, it's not statistically significant. It's not any meaningful difference. But if you look at the absolute numbers, the survival with the drug is a little smaller than the survival with the placebo. So because of this, as I said, this was done over a period of 12 weeks. So we do not know the long-term safety data from this drug. And we have not even talked about the cost. This is not going to come cheap, of course. So yes, cancer cachexia, it represents an area of unmet need. Absolutely, there have been a recognized need for a good medical intervention to target cancer cachexia for several decades now. And there have been a lot of research. And unfortunately, we have never had any good treatment. We have not had any good drug. Yes. Despite years of research and discoveries, there have been no drug, but that does not mean that we can just celebrate any new drug that has come out, because what patients need is not just a drug, but a drug that works and is safe. And our alien still has doubts on both these fronts. We do not know whether it works. We do not know whether it's safe. Now I want to show you something in this trial, and this is very relevant for drug trials, and that's why I wanted to show this. If you read the paper, then there is a section called role of the funding source. And usually these drug trials are funded and sponsored by the drug companies, which is fair, which is okay, as long as they're just planning the trial. But the problem is when I see things like this, the company, Helsinn Therapeutics, was involved not only in study design and material and data collection, but also in the interpretation and writing of the report. And this is very, very problematic. If we are running an industry-sponsored trial, at least interpretation should not belong to the trial. That's like, making me the judge of an essay competition where my own daughter is participating. I'll make her first. That makes no sense. Interpretation should be led to the audience. Interpretation should be led to an independent group of people. Or, like, as we can see that all trials will have authorship byline there. What is the role of the authors? Interpretation should be done by the authors. Writing of the report should be done by the authors. What does authorship even mean if the writing of the report was done by the study sponsor? What did the authors do then? If we ask ChatGPT to write our essay for college exams, we fail. And here, openly, the authors are saying we are authors, but the report was written by Helsinn Therapeutics. So yes, nowadays we collaborate very closely with the industry, and the industry runs most of the drug trials. That's fine, but the interpretation of the data and writing of the report should not be done by the industry. If I see this is a big red flag sign for me. And then let's talk about the editorial. Most of these important phase 3 trials are published in these big journals. And when they are published, these big journals publish an accompanying editorial to go with the trial. And the role of this accompanying editorial is to put the trial into context and to let the audience know what are the flaws with the trial, what are the strengths of the trial, is this trial practice changing. So, there is a lot of weight given to the editorial. The same trial that gets published with a very critical editorial, it is not very well accepted by the community and may not become practice changing. The same trial gets published with a very favorable editorial, then that becomes more powerful. So for these Romana trials, this was the editorial that was published to go with the trial, and the heading is targeting cancer cachexia. We are on the way. Already the title is super positive. And let's see what the conclusion of the editorial is. This is not the conclusion of the trial. This is the conclusion of the editorial that came with the trial. The editorial says, in conclusion, these two trials offer new hopes for more effective therapeutic strategies for cancer cachexia, where the anabolic properties of the drugs, exercise, and optimum nutrition should be integrated to produce measurable effects on patients' quality of life and clinical outcomes. It's a super positive editorial. If you read the whole editorial, this is a very, very positive editorial celebrating the drug. And then I was confused when I saw this, because I could see so many issues with the trial. I could see so many problems with the trial. And this was in 2016. In 2016, I was just a trainee. I had not even graduated from my oncology training. And as a trainee, I could see so many problems with the trial. But editorials in these big journals are supposed to be written by world-class experts. And I was confused, why is this world-class expert, supposedly the best expert in the world, and that's the reason why they are invited to write this editorial, does not talk about any of these problems in the trial. I was confused. And then I read the conflict of interest disclosure of the editorialist. And as you can see, this is the conflict of interest disclosure. You can see that the editorial writer has received fees from the exact same company that made this drug, Helsinn Pharmaceuticals. He has received lecture fees, advisory board member fee from Helsinn. Helsinn is the same drug that sponsored the trial. As the same company that sponsored the trial, it's the same company that made this drug. This is a huge problem. And since then, I have had a chance to speak with the editor of this journal as well in person, and I have highlighted this several times. And I think they are listening now, at least now this is going to change, that editorial should not be written by someone who has received fees from the exact same company whose drug is being discussed. And actually, we have proven this with our data that lead to bias. So, as an audience, we will look at experts. We trust experts. We go to conferences. These experts are giving us lectures on the podium, giving keynote lectures, plenary talks, discussions. But we need to be aware that experts may not always be right. Experts don't always give better advice, they just give more advice. But in oncology, we did this study and published this a couple of years ago, in which we looked at these top journals, and we looked at the editorial writers in these top journals, and we checked whether having any financial conflict of interest was significantly associated with writing an unduly favorable editorial. And as you can see in this table, having any conflict of interest was not associated, but having direct financial conflict of interest. And by direct, we mean receiving money from the exact same company whose drug is being discussed, then it was significantly associated with writing an unduly favorable editorial. And this is a big problem. This conflict of interest is, this is another paper that our group did. At least in the United States, for all its fault, they have an open database where you can check these things. As you can see, we know that conflict of interest is a big problem among oncologists in the US, but if you look at who is getting what amount of money, then there is 1% of those experts, those key opinion leaders, who receive a significantly high amount of money from the industry. There are, I guess, thousands and thousands who are getting $50, $100, $1,000. That is not as big a problem as these only 139 oncologists. They are very small in number, only 139, but they are receiving payments of more than 100,000 US dollars. So almost more than their salary. in some cases. So if you're getting 100,000 US dollars, 154,000 US dollars, 200,000 US dollars annually from the industry, then it's almost like a salary. It's almost like a job. And unfortunately, why are they getting this much amount of money? Because the industry thinks giving them this huge amount of money is in their benefit. And why would that be? Because these will be the same people who will be writing the guidelines, who will be writing the editorials, who will be going in the major conferences and telling us what to do. So we have to be very, very careful about this. I just wanted to highlight these points. Thank you.
Thanks, Bishal. That was great. I think we're done now. We can open it up to questions, comments.
Hello, sir.
Uh,
Sir, in that critical appraisal module, we had seen as you had forwarded earlier to our cohort. I think we have found 1 or 2 critical appraisal sessions that were pre-recorded and posted in that web page. So, is there any future journal clubs you are doing so that we can listen at Queen's?
Jin, do you want me to answer?
Yeah, Bishal, go ahead, because I think you're aware of the expansion plans.
Yeah, so right now we're like the routine journal clubs or masterclass that we used to do, they are in a pause because we had some change in personality at Queen's. Our department head had just left and so on. So there is some change in our planning committees, but that will continue in near future. In the meantime, like most of the grand rounds lecture on critical appraisal that I take, I also put it on YouTube, so you can also check several critical appraisals on, for example, dynamic trial in colorectal cancer and so on. I have put it on YouTube, so you can also check it out. The formal official masterclass through Queen's Global Oncology Program. There are several lectures, if you have not attended some of them before, they are all on the Queen's Global Oncology Program website. You can check them out. But the live sessions, they will resume probably in July or August, like after ASCO.
Bishal, there was a question in the chat about the difference between the Romana 1 and 2 trials.
And there was not much difference. They just conducted 2 trials. And I think they also had Romana 3 trial planned. I don't know what happened to that. And they were really hopeful that this drug would get approved. I think it did get approved in a couple of countries, like it was approved in Japan, but it did not get official approval from FDA. But I need to check whether Romana 3 happened and what happened to that trial. But Romana 1 and 2, there was no difference in methodology, and that's the reason why they reported them together. Honestly, I was surprised. I think they wanted to convince that the 2 trials were positive at the same time because they were basically similar trials.
Thanks, Bishal. There's a question in the comments. Should there always be secondary outcomes planned for RCTs?
No, it depends on the clinical need. It depends on the clinical question. For example, for drug trials, you will see secondary outcomes because you don't want to use a drug based on just one information. For example, if there is a new cancer drug, I would not want to use it simply because the response rate is 33%. I also need to know what the progression-free survival would be, what the overall survival would be, what the quality of life will be, what the toxicity will be. Similarly, for a drug like enamorelin or any cancer cachexia targeting drug, probably in addition to learning about muscle mass and muscle strength, you might want to learn about, for example, changes in appetite score, changes in fatigue, or change in mobility, for example. There are always more than one information that you want to know from a clinical trial of especially new products. So it is not wrong to have like 10 secondary outcomes. It's okay as long as it's pre-planned. What is problematic is it's not pre-planned, the results are negative, and then they try to salvage it by saying, okay, maybe we can find something positive here, and then they run a bunch of tests, and then they see that, okay, it improves sleep. For example, let's say enamoreline improves sleep, and they did not tell that they were going to look into sleep as a secondary outcome. But later on, they report that, okay, enamoreline patients who get enamoreline, they sleep better than patients who don't get it. So that is a problem. But if they include it as a secondary outcome before running the trial, and then before analyzing the data, and then they make appropriate statistical adjustments based on the power calculation, it should be fine.
Thanks, Bishal. There's a comment from Biju about if this is what's happening in the research, how can we believe it? These new promising trials, and I think that's the exact reason why critical appraisal is so important, and why it's important for all of us to develop these skills. It's I think much more kind of known in oncology circles, but it's as important in palliative care circles that we develop these skills for critical appraisal. And you know, Bishal is one of the leading experts for this, so I'm really happy that he was able to speak to all of you today.
Yeah, the question was, how should we believe it? The answer is, you are not supposed to believe it. That's the whole point.
Yeah, but sir, the question has been followed up with that comment. With limited experience and knowledge of critical appraisal by ourselves, how can we do it always? Because we cannot always depend upon your critical appraisals on all the papers. There's thousands of papers coming out in all the journals. So
sorry, I had misunderstood your question. Yeah, that's a good question. So I guess, as with everything that we do in our clinical practice, it just takes more and more training. So I think we need to do more of this critical appraisal official lectures, unofficially, like at your place. Whenever there is a journal club, or whenever there is a new paper that you're reading, like we should start reading it, not with an eye of what the paper has written, but with an eye of what are the problems of the trial. So try, like, usually when we do journal club in our places, we just want to tell what the paper has told. We just want to tell the audience that, okay, there was this trial, they did this was the median PFS, this was the median OS. But instead of that, we need to be more focusing on, was the trial designed right? How did they calculate the sample size? Did they achieve what they told us that they were going to achieve? Why has there been any manipulation? Is there any spin? So I think it's just it's just a change in mindset. Instead of, our mindset is, oh, wow, this is published in New England Journal of Medicine, so when I need to remember what the results are and I need to start using it. But instead of that, oh, they publish in New England Journal of Medicine, so maybe they are trying to fool us. So let's try to read it in a way that we have proper defense and not get fooled.
So I make a thumb rule out of what is happening, that I only choose those drug regimes and treatment regimes which is appearing in the latest edition of the textbooks, like the standard textbooks, which gives us more validation than the papers. So if a new drug, for example, comes on the market, then I don't use it immediately.
Yeah, I mean, textbooks are also written by us. Like, textbooks are also written by the same group of people who end up writing the articles.
We go from there.
Yeah, for example, I don't know how much of this audience is an oncology audience, but to give an example, it's a classical textbook teaching that in non-small cell lung cancer, if the histology is non-squamous, you are supposed to give pemetrexed. And if the histology is squamous, you are supposed to give gemcitabine as the chemotherapy partner with platinum. That's the classic textbook teaching. That even appears in exam. Like if someone is taking board exams, this question appears in exam. The patient has non-small cell lung cancer, the histology is non-squamous. What is the chemotherapy regimen you will use? The options will be cisplatin plus pemetrexed, and the other option will be cisplatin plus gemcitabine. And you are supposed to check on pemetrexed. But if we look at the evidence base, how that classical teaching came into place, it's based on a non-inferiority trial. And in that non-inferiority trial, they ran 20 subgroups. And out of those 20 subgroups, the p-value of 0.05 means you would expect one to be positive, even by chance. So out of those 20 subgroups, they found that, okay, pemetrexed has a p-value of 0.03 for non-niche corners. They did not control for multiple testing. And that became practice changing. That changed guidelines, that changed textbooks, that comes in our board exams. And if I have to take a board exam, I have to select on that answer to get the right marks. Even though I know that it's wrong. So yeah, the problem is much deeper than what we think it is. So in a sense, we have to start questioning everything. It's just like a blind man getting a new pair of glasses that with which he can now start seeing the world, and then having this critical appraisal skills is a tool like that. Once you know how to use the tool, you can use it, you can apply it to anything, and then you might start seeing things that you never expected to see, like practices that you have been doing for past 30 years. Probably they are wrong. Practices that we have been taught for the last 50, 60 years, and we have never questioned, probably they are useless.
Dr. Bishal, in that case, with your critical appraisals, you might be facing a hard task with all these renowned people.
Sorry?
With your critical appraisals and criticisms, you might be facing a hard task from all these renowned people and the pharmaceuticals, isn't it?
Yeah. But what can I say? If the emperor is naked, I have to say that the emperor is naked. I can't go with the crowd and say that the emperor is clothed properly.
Can there be a situation where the authors has received funds from a pharmaceutical industry and they do not declare it?
Sorry, your question was, what if someone has received money from the pharmaceutical company but they have not declared? Yeah, I know that might that I guess happens more often than we would want it to, but at least in the academic circle, especially in the developed world, it becomes a pretty big deal. It is a pretty big. It's a crime. If someone has received money from the pharmaceutical company and has not declared, it becomes a crime. I'll give you one high-profile example. Jose Baselga, he used to be the chief of Memorial Sloan Kettering, and a very senior person, has been the PI for many practice-changing breast cancer trials. And it was found that in many of his papers, he had not disclosed certain conflict of interest. He had disclosed some, but he missed disclosing some other conflicts of interest in several of his papers over 2 years. And that actually led him to lose his job. They fired him from Sloan Kettering because he failed to disclose conflict of interest. It came in the front page of New York Times. So, failing to disclose conflict of interest is a pretty big deal. But again, it's the question of transparency and honesty, and the whole scientific system works on the assumption of honesty and transparency, right? Like someone did a research in I don't know, Serbia, and claimed that they saw something in the lab research. And of course, like not everyone is going to replicate that or going to go and check whether they actually did it. We'll have to trust their methods that they have described. Okay, we'll have to trust necessarily that, okay, they probably did what they told us that they did. But yeah, scientific fraud is a big problem, and not disclosing conflict of interest is a fraud. You must know the story of bone marrow transplantation in breast cancer. Previously, when it was published, everyone was super excited. It was very intriguing results published from South Africa, and many people wanted to get bone marrow transplantation for breast cancer. But later on, when other people could not replicate those findings, and then they went to South Africa to see like what had happened there, they found that those trials never happened. Those patients never existed. It was like someone just made those things up.
Okay. So I think we have to end up the session, but what I would like to tell you is that this has been a very interesting session, and Jean came up with systematically how to critically appraise an article, and I think we got some of those points, and maybe if we go through the PowerPoints one or two times, we will understand more about it. When we and Dr. Bishal has come up with many points that, especially when we look at big journals and we believe, okay, this is a good article, but he says it need not be.
Hello, Sunil sir. Sir, we can't hear you.
Oh, sorry. Yeah, I don't have anything much to add. It has been a big pleasure and honor to be here today, and thank you, Jean, for asking me to be involved in this. At first, I was hesitating because I have never talked about critical appraisal to a palliative care audience, but yeah, I think these principles are applicable no matter what discipline. I'm happy to share my slides, and I'm also happy to. I think I can even give you right now a link to some other presentations on critical appraisal that I have made in the past, and in the future, if there is a need for more of these sessions, I'd be happy to help. And as we discussed earlier, I think Queen's Global Oncology Program will also continue with the masterclass, and if when that is happening, I think Jean can let you all know so that you all can participate in it. And as we discussed, the key is to continue to hone these skills, and this should not be like a one-time thing. We should continue to look into all the trials with these skills that we have developed. So I just shared a YouTube link there. Yeah, if there are a couple of lectures there on critical appraisal skills. So if that is helpful, please feel free to go through them.
Thank you both Jean and Vishal for this wonderful session, which actually asked us to look into the paper rather than believing in the conclusion or the journal article or people who has done research. So thank you for those messages, and we look forward to hear from you more maybe in the future. Thank you everybody.